Hello everyone. So I'm Claire MacDonald. I'm one of the principal investigators on the study and I work at Newcastle University and at the Queen Elizabeth Hospital just up the road. It really is lovely to see so many of you that took part in the study here today. Hopefully we'll have a great afternoon. We'll go through the results of the study and then there'll be an opportunity to get your feedback and for you to talk to us and us to answer any questions. So the study was MET-Prevent. And the first thing that we want to say is thank you to all of you. Okay? Thank you for taking part. Thank you for showing an interest in the study and an interest in research. We cannot do this work without people like you. And so I'd like to start with giving yourselves a round of applause for taking part in the study. It is only with people like you that we can hopefully get people living longer and having healthy, long lives. So before we dive into the results of the study, I just want to talk a little bit about why we do research and why we think it's so important. The first thing is to find out if treatments can work, and that's often done in very small groups of people or in laboratory conditions. And then the next question is to find out if those treatments really do work in the real world, in the kind of patients like yourself who use the NHS. It's also really important when we're doing studies that we work out how treatments are working and why they're working, because by understanding that allows us to improve on the treatments that we have. But we also want to understand what are the potential harms and risks of a treatment, because you'll know if you've ever taken a medication, lots of medications have the potential for side effects. And we also want to know, are the treatments that we are currently using and we're currently prescribing working as well as we think they are? Because there are lots of medicines that are incredibly old and have never been tested as rigorously as we would test a new medicine today. Why is it really important that we include people like yourselves? Well, we know that as we all get older, that tends to be when we accumulate more conditions, and we tend to live with conditions later in life. That means that we would need doctors and nurses, you need your GP, and you need the hospital more. And it also often means that you're taking more medications. And most people will notice that they go from taking very few medications in middle age to needing more medications as we get older. And it's really important that we understand how the treatments that we're prescribing work in that context, in the context of people who have other health problems, and in the context of people who have multiple medications. Because it's only by having that information that we can have the conversations with you about the potential benefits of a treatment and the risks of a treatment and whether or not it's right for you. So it would seem fairly common sense that the people who use the healthcare service the most should be represented in research the most. But we know sadly that that's not the case. And these are just a few recent examples. So in trials of cancer-related pain, a third of those studies had an upper age limit. So even though cancer becomes more common as we get older, older people are being excluded from those studies. We know that in the trials of COVID-19 treatments, about half of those excluded older people. And we know that the vaccine trials almost never included older people, yet the groups that were most adversely affected by COVID were older people. And across a whole range of different conditions, depression, heart disease, lung cancer, diabetes, osteoporosis, that are all more common in older people, there is an underrepresentation of people over the age of 75. And at Newcastle, we feel that this is really important and something that needs to change. And we've done a lot of work about how we make studies so that they include rather than exclude traditionally hard to reach groups. So we did work looking at how do we involve older people, how do we involve people who don't have transport or who live rurally or who have multiple conditions in research. And out of that came the Include guidelines, and they've been published to help other researchers improve the way they do research. And what we want to see is that when people design studies, they don't exclude older people, that they think about how to make it easy for people to take part in research. If you don't have easy access to transport, or you have mobility issues, or you have health conditions, you still need to be included in clinical trials if you want to be. It's also really important that people such as yourself are involved right from the beginning, so that we are doing the research and spending research funds on the things that are important to you, and that we are measuring the outcomes that matter to you. Because it doesn't really matter if we can improve a number if that's not something that matters in your day-to-day life. So they were the principles that we had when we designed the MetPrevent study. But the MetPrevent study was delivered by a whole team of us, some of whom you will have met. So you may have met me, or Bryony or Wendy, or people from the direct delivery team, because they were the researchers that came out to your home. But to get a study off the ground includes a huge group of us, from people like Helen, who you've already met, who organised today's event, Wendy and Bryony, but also people like Alison, who leads our R&D team. And I'd just like anybody who's been involved in the research study or supporting the Age Research Group, just to give a wave so we can get a sense of how many people in the room work on research. So can you just give a wave now if you were... And so you can see it is a huge team effort, and it's not just those of us who get to meet you and stand at the front that do that work. So just to recap, why did we think this was an important study? Well, we know that muscles become less strong as we get older, and those muscles tend to shrink and become smaller. And that's a condition called sarcopenia, but it's often not diagnosed. Sarcopenia affects people in different ways, but for people who do develop sarcopenia, it can make day-to-day activities more difficult, so classically getting the lid off a jar, getting up out of a chair, getting up out of bed. It makes you more likely to have falls and all the consequences of falls, such as being more nervous about going out on your own in the future, or the injuries that happen from falls. But also, if your muscles aren't in a great state, it makes it harder to recover from other illnesses. So if you get admitted to hospital with a chest infection or you have an operation, your recovery tends to be a lot slower if you don't have the muscle bulk there that a healthier person would have had. So we know that exercise helps with muscle, but not everybody can do exercise. And exercise is also really hard to sustain in the amount that you need to do, and so we need to look for other treatments. So why did we become interested in metformin? Metformin's been around since about the 50s. It's used to treat diabetes because it lowers blood sugar. But we know that metformin also works on the muscles, and it increases the ability of cells in the muscles to process energy. And so it looked like a promising candidate for improving the health of muscle. There was also a study in Indonesia that showed that older people who didn't necessarily have sarcopenia had a faster walking speed after taking metformin. So they were the clues that this might be a treatment that was effective. And so we wanted to answer that question. Does metformin improve muscle function in older people who have weak muscles? And if it does, how might it be working? So what did we do? Now, for those of you who took part in the study, you'll probably remember this, but we asked people 65 and older who had some sign of muscle weakness. So that was either that your grip strength wasn't as strong as it might once have been, or it took you a bit more time to get up out of a chair when we asked you to do the 5 times sitting and standing, and that you were walking a little bit slower than is normal. And we wanted to see if it would improve those. Some people couldn't take part in the study, even though we had an inclusive policy, and that's because either they didn't have any signs that their muscles had an age-related weakness, or they couldn't have metformin because metformin was a risk to them because of other health problems or other medication that they took. But for those of you who did take part in the study, you either got 500 milligrams of metformin 3 times a day, or the dummy tablet called the placebo. And I'm sure somebody will ask at some point, which did I get? And we're going to write to you all individually to let you know. We didn't think it was really appropriate to put it up on a poster in a meeting like this, but you will find out. And so the main things that we were measuring was your walk speed, and that's when we got you walking up and down the 4-metre piece of rope, your hand grip strength when you held on to that metre that doesn't move very satisfactorily when you squeeze it. For those of you who we saw on a nice day when it wasn't covered in snow and ice outside, we had you outside walking 6 metres. But we also measured how much muscle you had with the bioimpedance, and we looked to see what your quality of life was like and what you were doing with your day-to-day activities. You also very kindly gave us blood samples, and you gave us the stool samples as well, which I know were not always that easy. So how many people took part? 268 people expressed an interest in taking part, and we called all of those people to see whether or not they had any signs on a questionnaire of muscle weakness and whether or not it would be safe for them to take part in the study. 112 people looked like they were possible candidates for the study, and we went out to see those people mainly in their own home, where we did the initial tests and assessment and checked that you were willing to take part in the study. 72 people were randomized. That means 72 people got the placebo or the metformin, and 70 people completed the trial. And that's an incredibly impressive number. One of the reasons that sometimes researchers are a bit reluctant to include older people is they think that you might be less likely to finish the trial because of health problems. And actually, in most trials, somewhere between 75 and 80% complete. So the fact that between you, 97% completed is really very impressive. And there's a lot for us to learn from that point alone. Again, the average age was 80, and somebody at the last meeting asked us about the age range, and that was 65 to 96. And we even went out to see people who were over 100 to see if they were suitable for the study. So there was genuinely no upper age limit. 60% were women, and that's pretty typical when we do studies. Just over half of you who took part walked with a stick or a walking aid. And that's important because that's fairly typical of the type of patients that myself and Professor Witham would see in clinic. And this is all about making sure the people that we involve are like the people that we work with in our NHS day-to-day care. And your average fitness was very similar to the people we see in clinic as well. So, did you take the metformin? Yes, you did. But interestingly, 4 out of 10 people in the metformin group had to stop taking the medication, compared to 1 out of 10 in the placebo group. And that's often an indication that people are experiencing side effects with the study medication. And so that's the first interesting thing that we've seen. The next question, and the bit that you're all waiting to find out, is did it work? No, it didn't. Walk speed was the same between the people who took metformin and the placebo at the beginning of the study and at the end of the study. And we looked to see, are there any groups that it does work in? Does it work better in women than men, or does it work better in younger or older people? And there was no difference, even when we did what are called subgroup analysis. What about side effects? Well, we know that anybody can experience illness at any time, and that is more common when we're older. And over a 4-month period, lots of you would have got coughs, colds, or other health complaints. And we know that people sometimes might need admitted to hospital. But what we're interested in is, are there any differences between the group of you who were taking metformin and the group of you who were taking the placebo? And we did see some differences. So we saw that there were more people in the metformin group that had medical issues. So 110 versus 77. And we also saw that there were more people who had side effects that we suspected were related to metformin. Because when we look at the side effects, myself and Professor Witham don't know what you're taking either. But we know that metformin is associated with upset tummies, diarrhea, nausea. We also saw that more people who were taking metformin were admitted to hospital as well. And these findings were quite a surprise to us. We know that all medications have side effects, but this shows us that they are more common with metformin than perhaps they were previously thought. And again, that goes back to the fact that often the tests have been done in groups of people who are younger, who don't have other health problems, who aren't taking other medication. And that's why it's really important to be doing research in people who are representative of the people who need to use these treatments. So to recap, the people in the trial, so you, resemble the type of people that we're seeing in clinic, and that's a real success because it doesn't happen all the time. Lots of you have really quite significant muscle weakness, but despite that, you were able to finish the trial, and actually the completion rate for the trial was much higher than people might have suspected. But metformin didn't improve your muscle strength, it didn't improve your muscle size. And metformin didn't improve your quality of life either. There was a suggestion that your quality of life might be slightly worse in the metformin group, and that makes sense if you're having more side effects from the metformin. So is that disappointing? Not really. Research is complex, and it's all part of a puzzle. And it's really important for us to know what doesn't work as well as what does work. And it helps us build a picture. It may be that metformin is helpful for some people who only have very mild muscle weakness, but not for people who have more advanced muscle weakness. And that's important that we understand who it is that treatments are helpful for, and who it is, as we've seen in this case, the side effects outweigh the benefits. So where do we go from here, and what do we do next? Well, we need to get the results published so that other doctors know this information and can build it into their research and into their practice. And we need to present these results at other scientific meetings, and that starts in a couple of weeks' time with the first conference that we're presenting this at. We've got lots of other opportunities to answer scientific questions. So those blood samples that you gave, the stool samples that you gave, they're still being analysed, and they will help us answer some of the questions that we want to know about how metformin works and why it didn't make the changes that we thought it might. And there are also future studies, and you will see on your tables there's some information about a study called Multiple, and that's an opportunity to sign up for a registry where we can come and measure your muscle again, but also invite you then to take part in future studies looking at alternative treatments that may be a combination of exercise or nutritional supplements or other medications. And so the journey continues until we try to find something that does help. So again, I'd just like to say thank you very much for your participation.